Welcome to the deep dive. We're taking a look today at some revision material you've shared with us, diving into a really specific medical topic to pull out the absolute essential knowledge.
That's right. Think of this as, you know, turning those dense notes into a clear conversational breakdown. We're focusing on epididymal cysts, often called spermatoceles.
Spermatoceles, right?
Yep. We've got a stack of information covering pretty much everything you need to know, from what they are to how they're managed, and we're going to navigate it together.
Okay, great. Our goal is simple. Get you the core facts from this source material efficiently and hopefully memorably. Let's jump in and unpack this. So, kicking off right at the beginning, what exactly is an epididymal cyst? The notes mention spermatocele as another name for it.
Yeah, they do. The source material defines it very clearly. At its heart, it's a benign, fluid-filled sac.
Benign, okay, that's key. Non-cancerous.
Exactly. Benign is a key word there, meaning non-cancerous.
And where does it specifically show up, like location-wise?
It develops within the epididymis. That's that small, sort of coiled tube structure situated right on the back of the testicle.
Okay.
The notes emphasize that they're typically found in the head of the epididymis.
Right, in the head. Okay, so benign, fluid-filled on the back of the testicle. What does it actually look or feel like based on the notes?
Well, the description we have paints a picture of a smooth extratesticular cyst.
Extratesticular.
Yeah, extratesticular is important. It means it's outside the testicle itself, even though it's attached to that structure behind it,
Gotcha. Outside the main body of the testis.
Precisely. The notes add that if these cysts contain sperm, they're specifically called spermatoceles.
Ah, okay. That's the distinction.
Yep. And again, they are benign and very often don't require any treatment at all. But their clinical significance can vary, which is why understanding them is important. They might prompt investigation just to be sure of the diagnosis.
That makes sense. Starting with benign is already, reassuring context. So if they're common and usually harmless, why do they form? What's the underlying cause? The etiology, according to the source material.
Well, the notes are pretty upfront that the exact cause isn't completely understood.
Yeah.
But the primary theory they present is that these cysts develop because of an obstruction.
Like a blockage.
A blockage, exactly, in the tiny ducts within the epididymis.
Like a plumbing issue, almost. A traffic jam for fluid.
That's a good way to put it, yeah. That blockage prevents normal fluid flow, and this accumulated fluid pools up, eventually forming the cyst.
The notes also list some other conditions that seem to be linked. That connection is quite interesting.
It absolutely is. The source material highlights some fascinating associations. It links epididymal cysts to conditions like cystic fibrosis.
Really? CF?
Yeah, often specifically due to a congenital absence of the vas deferens, which, directly relates back to that obstruction idea.
Okay. That makes sense.
They're also linked to von Hippel-Lindau disease, adult polycystic kidney disease, and, surprisingly, even maternal exposure to diethylstilbestrol.
Wow.
Yeah, so these connections sort of underscore that while they're often standalone, they can sometimes be a clue to a broader, perhaps genetic picture.
Wow, those are definitely not connections I would have immediately made. What about fertility? That's going to be a natural concern when discussing structures near the testicle. Do the notes address whether these cysts cause infertility?
That's a crucial point. And the source material is really explicit here. It states very clearly that there is no evidence of epididymal cysts causing infertility.
Okay, that's huge. Good to know.
Yeah, a significant takeaway. Definitely offers reassurance.
Okay. Moving on then, are there specific things that make someone more likely to develop one? What do the notes tell us about risk factors?
The source lists a few key risk factors. A history of trauma to the testicle, or maybe a previous infection in that area, that's one.
Right.
Having undergone previous surgery in the scrotal area is another. And lastly, congenital abnormalities of the epididymis itself can predispose someone to developing these cysts.
Okay, so trauma, infection, surgery, or just being born with a slight variation there. Let's dig a little deeper into how that blockage mechanism works, because the pathophysiology section in the notes seems to really focus on this.
It does, yeah. It reinforces that idea they form due to this blockage in the epididymal ducts. When fluid can't flow properly, it backs up, leading to accumulation.
Right?
The notes describe the cyst contents as typically clear or sometimes milky fluid. And they mentioned that the cyst wall is lined by epithelial cells.
Okay.
Which, fits perfectly with the idea of trapped fluid within a ductal structure.
And this is vital, right? When someone discovers any lump or swelling in this area, the immediate worry is about what else it could be. What does the differential diagnosis section cover? What are the key things you absolutely must distinguish an epididymal cyst from based on this material?
Yet this is arguably one of the most clinically important sections for revision. Really key. The notes several critical conditions to consider.
Okay.
First, a hydrocele. This is also fluid accumulation, but the key difference is location. It's around the testicle within the tunica vaginalis, not within the epididymis itself.
Oh, okay, so different location.
Exactly. Next, a varicocele. This involves enlarged veins in the scrotum, often described as feeling like a bag of worms. Different texture, different cause.
Bag of worms, right. Heard that one.
And crucially, testicular tumors. These are masses located within the testicle itself.
Inside the testis.
Inside. And they are, understandably, the primary concern people have when they find a scrotal lump. So distinguishing between a mass inside the testicle and a cyst outside it is paramount.
Absolutely critical.
The notes also mention inflammatory thickening of the epididymis, which could maybe feel like a cyst on palpation, but it's inflammation. And beyond these common ones, the notes list other possibilities for extratesticular scrotal masses, things like adenomatoid tumors, abscesses, cystic lymphangiomas, even lipomas.
So a whole list of possibilities.
Yeah, but the absolute core message from this section is the need to confidently differentiate the usually benign epididymal cyst from these other things, especially a testicular tumor.
That distinction inside versus outside the testicle sounds like a critical first step in the exam. So how common are these cysts in the general population? What's the epidemiology look like?
They are surprisingly common. The notes cite a prevalence in the UK of around 30% among adult men.
30%? Wow, that's a huge number. It means you're very likely to encounter this either personally or, clinically.
Exactly. It makes sense why this is a high-yield topic for revision, right?
Okay.
They tend to be more common in middle-aged and older men.
Okay.
The notes specifically mentioning a higher occurrence after age 40. They're quite rare in young children.
And what about their physical characteristics within that population? Any patterns?
Yeah, the notes describe them as often being bilateral,
Both sides.
meaning they can appear on both sides, yeah. And sometimes multiloculated.
Multiloculated.
It just means they have multiple small compartments within the larger cyst. It's not usually a big deal, just how they can sometimes form.
Okay.
The incidence of diagnosis in specialized healthcare settings is cited as about 100 per 100,000 men. While they're rare in children overall, the notes say they can occur around puberty, with an estimated incidence of maybe 5–20% in that age group.
Interesting.
But yeah, the notes acknowledge that estimating the true prevalence in the general population is challenging because, well, so many are asymptomatic.
Right. People might not even know they have them. So if someone does have one and notices something, what would they typically notice or feel? What's the clinical presentation we should look for?
The most common scenario, according to the notes, is that they are completely asymptomatic.
Nothing at all.
Often nothing. They are frequently found almost by accident, during a routine physical examination for something else entirely.
So many people might have one and just not even be aware.
Precisely. However, they can cause symptoms. The notes list several potential issues. The person might feel a painless scrotal mass or swelling.
Okay.
They might describe a feeling of heaviness down there.
Heaviness, right.
Or they could experience actual discomfort, particularly, say, during physical activity.
Do they tend to appear suddenly, like overnight, or is it a slower process?
The material says they develop gradually. It makes sense, right? They result from a partial obstruction of those tiny ducts that carry sperm, allowing fluid to sort of back up slowly over time.
Okay, gradual onset.
Now, on physical examination, the notes provide key identifiers. They're typically non-tender.
Not painful to touch.
Right. Smooth, soft, and often relatively small. Less than 1 centimeter is common, though they certainly can grow larger.
Okay.
As we mentioned, they are frequently bilateral and multiple. And critically, this is for distinguishing them from a testicular tumor. The notes emphasize that on examination, the testis itself can be felt separately from the cyst.
Ah, that's the key physical finding again.
It's a vital differentiating factor. The notes also add that often, based on this physical exam alone, they can be clearly distinguished from tumors, and maybe no further investigation is strictly needed unless there's real uncertainty.
That makes sense. Physical exam is the first step, and that ability to feel the testes separately sounds like a really key sign. But if there is any doubt after the exam, how are they typically investigated? What do the notes say?
Right. If there's any uncertainty after the physical exam, The notes strongly recommend a scrotal ultrasound.
So ultrasound is the go-to imaging modality here.
Absolutely.
Yeah.
Ultrasound is excellent. It's great at confirming the presence of a cyst, showing it clearly as a fluid-filled structure, and just as importantly, ruling out other conditions, particularly those more serious masses within the testicle that we talked about in the differential diagnosis.
So
The notes specifically advise against just sticking a needle in for diagnosis fluid aspiration. They say it's rarely useful or necessary for diagnosis or treatment.
right, not the first step for figuring it out. What about that classic move with a light transillumination? Does that play a role here?
Yes, good question. Transillumination is mentioned. Epididymal cysts and spermatoceles, because they're fluid-filled, typically do transilluminate.
Meaning light shines through them.
Exactly. If you shine a bright light through the scrotum in a dark room, the light passes through the cyst, making it glow, essentially.
Yeah.
The notes contrast this with other causes of scrotal swelling. Things like testicular cancer, varicoceles, even hydroceles sometimes, or hematoceles, they behave differently. They usually don't transilluminate, or not as clearly.
Okay.
So the instruction is pretty clear. If a lesion cannot be transilluminated, if it blocks the light, then a scrotal ultrasound is essential. It helps differentiate it from a solid mass, which is the pattern you'd expect with a tumor.
So transillumination can be a useful bedside test, maybe points you in the right direction, but if it's negative or unclear, ultrasound is the necessary next step.
That sums it up perfectly.
Okay, so based on the exam, potentially transillumination, and often confirmed by ultrasound, you've got the diagnosis. It's an epididymal cyst. What's the management approach outlined in the source material? What do you do?
Right. Well, the most important takeaway here, the main message for management, is that for the vast majority of these cysts, no treatment is needed at all.
Really? So the primary management is just reassurance.
Exactly. For small, asymptomatic, painless cysts, the notes indicate that explanation of the condition and reassurance are sufficient. No medical or surgical intervention is required.
Okay, watch and wait, basically.
Pretty much. However, if a cyst becomes large, starts causing significant discomfort, or is, cosmetically bothersome to the person, then the notes list surgical excision as an option for removal.
So surgery is an option if needed. What about trying to drain it with a needle? Is that ever done for treatment?
Needle aspiration is mentioned, yes, but the notes caution that it's often only a temporary solution.
Yeah, it comes back.
Fluid tends to reaccumulate pretty rapidly after simple aspiration, so it might provide temporary relief, but often not a long-term fix.
And are there any medical options like pills or creams?
The notes do mention prescribing NSAIDs,
Uh,
non-steroidal anti-inflammatory drugs like ibuprofen,
right.
but only if the cyst is causing pain or discomfort. They're treating the symptom, the discomfort, not the cyst itself.
Makes sense. When is surgery more strongly recommended then?
Well, surgical excision is generally recommended in children who have persistent scrotal pain or cysts that don't seem to be resolving spontaneously.
Okay, for kids with persistent issues.
And symptomatic adults can also opt for surgical removal if the discomfort or size really warrant it, impacting their quality of life. The notes also describe another procedure, percutaneous aspiration, followed by sclerosant injection.
Sclerosant, what's that?
It involves draining the cyst first, like with aspiration, but then injecting a substance, the sclerosant, which is designed to irritate and scar the inside walls of the cyst.
Ah, to make them stick together.
Exactly. The hope is that the walls stick together and obliterate the space, preventing fluid from reaccumulating. The notes state this procedure has a success rate of around 85% for spermatoceles or epididymal cysts.
Pretty good.
But it's worth noting that sometimes multiple procedures might be needed to achieve full resolution.
Okay, another option there. Is there any chance they just disappear on their own eventually?
The source material does mention spontaneous resolution as a possibility. So, yes, they can go away by themselves, but it notes that this can take a considerable amount of time. The notes cite a potential time frame of up to 50 months.
50 months, that's over 4 years.
Yeah, quite a long time to wait if it's bothering someone. So, while possible, it's not always a practical expectation for symptomatic cysts.
Okay. What's the general long-term outlook? The prognosis for someone diagnosed with an epididymal cyst?
According to the notes, the prognosis is overwhelmingly excellent.
That's good to hear.
Yeah. Given their benign nature, they don't represent a significant health risk in themselves. They're not cancerous. They don't turn into cancer. And if treatment is pursued, like surgical removal or that aspiration with sclerosant, it's usually curative. Recurrence after successful treatment is noted as uncommon.
So generally a very good outcome. Are there any potential complications at all, even though they're typically benign? Anything to watch out for?
The notes reiterate that complications are few and far between,
Hmm.
precisely because the cysts are benign.
Right.
The rare complications listed include the possibility of infection developing within the cyst,
Okay, that's possible.
significant cyst enlargement causing more pronounced symptoms, or, as we just mentioned, recurrence after treatment, though uncommon. Torsion of the cyst itself, where it actually twists on its stalk, is mentioned but explicitly described as extremely rare.
Extremely rare.
And infections are also noted as uncommon events. So, overall, complications are not a major concern.
Okay, that feels like a really comprehensive walkthrough of the information from those notes. We've gone from the basic definition and the cause right through the presentation, how you diagnose it, all the way to management and the generally excellent prognosis.
Yeah, I think we covered the key points.
Yeah.
We've seen they're very common, usually harmless, and often require little more than accurate identification and, importantly, reassurance.
Yeah.
The absolute key, which was stressed repeatedly in the notes, is being able to confidently distinguish them from other scrotal lumps, particularly testicular tumors,
Right.
using those examination findings like feeling the testes separately and the investigation tools like transillumination and especially ultrasound when needed.
So what's the practical takeaway for you, the listener, especially if you're revising for something like the MSRA? This structured approach hopefully helps you compartmentalize and recall those high-yield facts. Benign, fluid-filled, behind the testicle, often asymptomatic, diagnosed mainly by exam and ultrasound, and crucially, usually needs no treatment.
It does raise a compelling question, doesn't it, about the diagnostic process in general. How often do seemingly concerning symptoms, like finding a lump, turn out to be something relatively common and completely benign? It really underscores the critical role of a thorough differential diagnosis in medicine.
Absolutely. Well, if you're preparing for exams and find this kind of structured, high-yield summary helpful, you can find more valuable resources structured just like this over at passmsra.com.
And for additional free materials to help boost your revision, make sure to check out freemassery.com as well.
That wraps up this deep dive into epididymal cysts based on the revision notes. We sincerely hope this has been a valuable addition to your learning and exam preparation.